Good afternoon, everyone. Today I'll be presenting a case on refractory secondary glaucoma following pterygium excision with autograft. So, my patient is a 54-year-old female from Kadalur, presented with chief complaints of pain, redness in left eye for the last 14 days. It was insidious in onset, constant, dull aching in nature, without any aggravating and relieving factors for the last 2 weeks. There was no radiation of pain. It is associated with diminution of vision and intolerance to ambient light. There were no history of colored halos. Patient gives this following brief medical history. In June 1st week, patient underwent left eye pterygium excision with conjunctival limbal autograft. 40 days later, she developed eye pain and diminution of vision along with photophobia. At that time, the patient's vision was 360 and cells were anterior chamber cells were 2+ with mild corneal edema. IOP was measured as 44 millimeter of mercury and not controlled on maximum medical therapy and referred to her college. At the time, she was on three topical AGMs, one topical prednisolone drop, oral acetazolamide, and IV mannitol. Still, the IOP was remained high. Patient has no systemic comorbidities. On examination, general and systemic examination was within normal limits. Coming to left eye examination, vision was 560 with marked conjunctival congestion with localized corneal haze with vascularization nasally at the area of pterygium excision, and the anterior chamber depth was Van Herrick's grading 2 with cells 2+, and the pupil was 4 mm fixed dilated. There were pigments on the anterior lens capsule with broken synechiae, and IOP was 34 millimeter of mercury by GAT. These are the gonioscopy images. The right eye showed open angles and the left eye had slightly narrower angles. Coming to fundus examination, the right eye fundus was within normal limits. Left eye media was hazy due to cataract and the disc color was normal, but cup disc ratio was around 0.7 with concentric NRR thinning. And rest, there were no evidence of RNFL defects or no evidence of disc hemorrhages. With the central corneal thickness of the right eye was 640 microns and left eye was 610. OCT, RNFL, C fields were not reliable as the signal strength was poor. So with no further delay, we started the patient. We stopped topical prednisolone in view of steroid responder, and we have given topical AGMs and intravenous mannitol to lower the intraocular pressure. To reduce the ongoing inflammation, we have started on fluorometholone eye drops. 48 hours later, intraocular pressure was 36 millimeter of mercury. There was transient drop in IOP noted post mannitol, but the IOP remained elevated otherwise. The anterior chamber became quiet. So we have proceeded with trabeculectomy with mitomycin C augmentation. So these are the post-op images. By end of 3rd week, patient cornea became clear and the pressure was maintained at 12. So unique features were, this is the uncommon post-pterygium surgery complication. There were multiple potential causes of IOP elevation. There is mixed mechanisms. And there is resistance to maximum medical therapy, and successful surgical outcome was seen in this case. So clinical implication, so elevated IOP post-pterygium excision, it can be due to steroid-induced or pre-existing glaucoma, uveitic glaucoma, altered downstream drainage of aqueous due to the pterygium surgery per se, or altered corneal biomechanics. So my take-home message is, you should recognize the multifactorial causes of glaucoma, and you should use steroids judiciously in post-operative management. Early surgical management is important in refractory cases like this, and personal treatment approach to different cases. Thank you.
I just want to ask you, Doctor, first of all, it's a very nice case that you've shown us, but I just wanted to ask you that don't you think that the optic disc in the concerned eye, it was definitely showing evidence of glaucomatous damage from the very beginning. It couldn't have been that in 1 month's time, the optic disc could have shown these kind of changes. So what do you feel this is? Would you like to revise your statement, your diagnosis?
Maybe for the last 40 days since the pressures were high, maybe this in 40 days there could have been chance of the optic nerve being damaged because of high IOP, because it was in range of 30s to 40s even on medical therapy.
So you feel that the optic nerve could have shown such rapid change and the CDR ratio, that inferior neuroretinal rim almost there's thinning? Or would you like to prefer to say that yes, the patient was a case of glaucoma, was therefore more prone to being a steroid responder, and therefore the moment the steroids were given, he showed a steroid response, which could have also been seen in the other eye, fellow eye, which was not seen, and therefore this patient landed up with this? Would you like to say that, or would you like to stick to your diagnosis? Entirely up to you.
Actually, we didn't come to the proper diagnosis, because after stopping the steroids also the IOP was not controlled. Even
It takes time. It takes time.
Even after controlling inflammation, So maybe due to the effect of steroids, there is chronic damage to the tubercular meshwork. So even after stopping the steroids, the IOP is not controlled. So it might need trabeculectomy for that.
Do you want to explore the idea of it being completely unrelated to the pterygium surgery?
It might be the cause.
In that case, what will be the diagnosis? The cause of glaucoma? You explained so many clinical features, right? There was pigmentation on the endothelium.
Yeah, it can be uveitic glaucoma.
Correct.
Or,
So steroid-induced glaucoma doesn't present a clinical picture like this. So that's completely out. It is not a steroid-induced glaucoma, and also it takes, how long does a steroid take to cause an IOP spike?
More than 6 weeks.
More than 6 weeks? So no, it can in a couple of weeks also, but in the time difference between your pterygium surgery and the development of very high IOPs was only 40 days.
Yes, ma'am.
Right? So that itself doesn't really fit in that very well, and also for it to cause so much of RNFL damage also within those few couple of weeks is also a little not understandable. Yeah, so it looks more like an unrelated uveitic glaucoma to me as well, on the basis of the clinical features. It's very straightforward.
But thank you. It's a good thing for us to think about. Thank you very much.